Okay, so good afternoon, everybody, and we'll be discussing about the journals this month, and there are quite interesting articles which have come with regards to a mixed bag in pediatric endocrinology. So this is our monthly activity, and we'll continue forward with four interesting articles which we'll be discussing in detail in that regard. So last time our focus was predominantly in terms of therapeutics. This time we have got a more wider perspective in which we have got a combination of journals we'll talk about. The first, of course, is about the treatment option, the novel treatment options which are available. Then we have got ones with regards to the diagnostic strategies which are there for the management and assessment of type 2 diabetes, a novel way of improving the care of children with diabetes. And then we have got an article about the impact of hypothyroidism in mother on neurodevelopmental outcome in children. So there's going to be a mixed bag of articles. We will start off right from there. So why really do we need to do a literature review? That is a key question which often we will ask, and often if we do not look into the literature, we will be left behind in terms of what new developments are happening. So the 4 points we want to look at in a paper which is coming is it valid? Is it generalizable, particularly if it's been done in a different environment? Is it valid and generalizable for our population? Is it a novel work which warrants a change in our practice? So this is what are the 4 criteria that we'll try to assess all the 4 journals and try to see if we need to change our practice from that perspective or not. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of innovative resources and courses. We have got fellowship programs and diploma programs in pediatric endocrinology. There are 3 programs which we run every month. One is a grand round, then this is journal club, and then we've got a PG lecture series which is run from that perspective. There are publications and mobile application which is available. So today we'll talk about 4 topics. The first one I'll start off on is a very interesting one, is the effect of semaglutide in adolescents with obesity. Now, we all know that obesity in children is increasing day in and out, and a lot of complications are happening right now, along with the increased risk of cardiovascular complications, which happen subsequently in life. So we'll go into the 4 key issues. Why was this study done? How was it done? What did they find? And whether it should change our practice or not. These will be the 4 questions we will go on to that. So now we all know that obesity is a major challenge now, and we are seeing a lot of obesity complications in young ages. The Endocrine Society guidelines show that if we are able to cut down on BMI, we are talking about reductions in systolic blood pressure, triglyceride levels, along with improvement in the metabolic profile. So it's not just about long-term complications. The short-term complications will also improve if we are able to do a good control in terms of BMI. Now, what we really want to achieve in our obese child or adolescent is stabilization to begin with. We don't want a massive weight loss. We want approximately 7 to 10% loss in weight. Now, you can say it in forms of weight or in form of BMI. That would be the sort of loss we're talking about. Less than 1.5 kilogram per month. Our overall loss of approximately 10% in BMI standard deviation score is what we want to achieve. Very importantly, if a child is growing normally, we would expect the BMI SDS to come down gradually over follow-up. We don't need to have dramatic loss in that perspective. Now, what options do we have in terms of obesity? So when we're talking about obesity, it's basically an imbalance about how much we are taking in and how much we are spending. So we can either focus on the ventromedial hypothalamus, which is a key regulator of satiety, or we can talk about resting energy expenditure. Now, most strategies are focusing more in terms of reducing calorie intake rather than increasing expenditure. And that's important because most of them have not been found to be very effective. So theoretically, we can inhibit the lipase enzyme, which will basically allow the loss of fat in the stool. So this is how orlistat works. This is one mechanism which is approved beyond 12 years of age in children. We can use metformin, which can cause peripheral sensitization and growth hormone in certain subset of patients like Prader-Willi syndrome. But these medications are not anti-obesity medications. Metformin is specifically recommended for children who have got type 2 diabetes, but not other indications. So we need to consider that it's not an anti-obesity medication. Growth hormone only in individuals who have Prader-Willi syndrome shall we think of it as an anti-obesity medication. The other option, of course, which is quite attractive is the use of GLP-1 receptor analogs. Now, we all know that GLP-1 is an incretin, which is secreted in response to intake of carbohydrate from the duodenum. It has got three major effects. One is to reduce the satiety at the level of the ventromedial hypothalamus. Second is to prolong the gastric emptying along with increased insulin secretion. And insulin is also something which induces satiety. So in a way, if we use GLP-1 receptor analog, we will be able to achieve a good amount of satiety, bloating, reduced food intake, and there will be improvement in terms of weight. The other option could be that if we can block the somatostatin pathway using octreotide, this again is a very specific therapy for hypothalamic form of obesity, not for other forms of obesity. In individuals who have leptin deficiency, leptin replacement has been used, but again, very specific and targeted intervention. There is also studies about the use of MC4 receptor agonist, which is setmelanotide, particularly for POMC deficiency and leptin receptor defect. So these are areas. And now, interestingly, there is a monoclonal antibody which has been developed against activin, which increases the muscular activity. So these are the broad drugs which are being used. Now, what drugs are approved for use in adolescents, Dr. Manoj?
The GLP-1 analogs has been approved.
Okay.
Metformin has approved, and setmelanotide.
No. So most important, of course, approved is orlistat. That is the drug which is approved for long time. Now, metformin is not approved for obesity treatment. It is approved for type 2. The other drug which has recently been approved is a daily injection of liraglutide, 3 milligrams daily. And recently, phentermine combination with topiramate has also been approved, but this is a centrally acting agent. So there are 3 agents which are approved currently for management of obesity. Now, what we are seeing is that most patients who come to us with obesity have a BMI standard deviation score of approximately 2.5 to 3. If you want to have a meaningful reduction, you're talking about a fall of approximately 0.5, which is pretty high and difficult to achieve. So we'll see how much do we expect with these medications. Now, orlistat, of course, is a medication which is basically working in terms of improvement. And this is a study which was a trial. This is the only trial which is available for orlistat. What we see that there is a reduction which happens in terms of the BMI. Now, what you're seeing here is that there is a reduction, but we are talking about BMI points of approximately 1. So the maximum reduction is happening is 1. So when you talk about 1, we are talking about 4 to 5% reduction in BMI. So if somebody has a BMI SDS of, let's say, 2.5, and you're reducing it by around 0.1, it is not going to make a huge difference. In terms of weight, again, if you see the weight loss is only 3 to 4 kilograms, so it's not going to be hugely effective. The problem with orlistat is also that it will cause gastrointestinal symptoms, bloating, it will cause steatorrhea, leaking, and all the other problems happen. So this is a drug which is not very effective. And what is recommended is that if you do not see a benefit in the first 12 weeks of treatment and the reduction in BMI SDS is less than 5%, this drug is not going to be more effective. You should stop at that point of time. So this is not something which is very helpful. Now, phentermine topiramate is the second group of drug which has been recently published. This data is from 2022, particularly in children. And what we are seeing here, and this is the percentage change of BMI from baseline. Now, they had used a mid dose, a lower dose, and a higher dose of phentermine topiramate. Now, what you can see is that the higher dose is causing a reduction of approximately 10 to 11%. So this may be a reasonable reduction that you can talk about. So 10% reduction. But the problem of these drugs are that they are all centrally acting, and that the history of centrally acting drugs has been very bad. Many of the drugs had actually had to be banned and removed because they caused depression, they caused suicidal tendencies, because this is the same area that you have the reward area and the other hypothalamic area. So rimonabant, sibutramine, a number of drugs had actually to be removed. So we would be very cautious in using these drugs in adolescents. So this is something which has been approved, but most people are not using at the moment in terms of pediatric age group. Now, there's a reasonable benefit, but this is a centrally acting drug. Now, what about the use of GLP-1 receptor analog? Now, liraglutide, as Dr. Manoj was saying, is approved beyond 12 years of age based upon this study published in NEJM. And what you can see is the change in BMI standard deviation score. So the minus 0.3 is the rough change in BMI standard deviation score. So what we are looking at here is that this would be somewhere around 10%. So 10% decrease will happen in this figure. But what's very important is once you stop the treatment, what is happening? There is again an increase which is happening towards the end. So there is a rebound phenomena which is happening. So this has been approved, but there are issues that you have to give a daily injection of 3 milligrams, which itself is a problematic issue. You need to have a patience because the effect is not too much. And then there is a bounce back which happens also on follow-up. So all the 3 medications which are FDA approved for management of childhood and pediatric obesity are not up to the mark in terms of efficacy, in terms of durability, and in terms of ease of treatment. So we have to think of options which are there in that perspective. That brings us to this new molecule, which is semaglutide. Now, many of us are aware about the oral preparations of semaglutide, which has been approved for the use in adults. But what we're talking today is the injectable preparation of semaglutide, which is to be given once a week. This preparation is unique because it has got specific alterations in the amino acid profile to allow decreased degradation by DPP-4, having anomalous fatty acid binding, and the fatty acid binding then will bind to the proteins, reducing renal clearance. So overall, the half-life of GLP-1 will become more. And this allows administration in a week. So this is a good preparation, once a week preparation, definitely going to cut down the number of injections and maybe more favorable in that perspective. So this drug is being used and it has been tried in adults with obesity. Now, if you look at the adult picture, the change was approximately 16%. So this is a substantial increase. We're talking about 5%, 10%. This is 16%. Now, 16% would mean that if somebody is at 2.5 standard deviation score, roughly you're talking about that they will come down to around 2. So this is a reasonable decrease and they're coming down to a different category altogether. So this was a good drug to look at in terms of adults. Now, of course, we need to have evidence which is there in terms of the adolescent population in that perspective. So now we know definitely there is a need for a new drug which can improve the outcome with better effect without causing adverse effects. So now how did they go ahead with this study? So the design of the study was a very elegant design. It was a randomized, double-blind, placebo-controlled, phase 3A, multi-centric trial. So it's a big trial overall in the globe. They had 37 centers, and this was pretty much around the time of COVID. So you had presented last time about liraglutide and Prader-Willi. So I think simultaneously this study was also going on of weekly semaglutide in specific obesity population. So that was a big problem about COVID around that time. Now, the analysis in this case was intention to treat. Now, what do you mean by intention to treat analysis, Dhwani? Vibha? So, intention, Manoj? So, when you say intention to treat, it basically means that you will assume that if a patient has not taken the medications, if the patient has taken it only for a week or a 2 week, you will include him in the treatment group. So you get the point? So that it is not happening that you may actually ignore those patients. Maybe somebody lost to follow-up or somebody not performing well, you will say, I will remove that patient. So intention to treat is a very specific way which ensures that every patient who is enrolled in the treatment arm will be considered in the treatment arm, irrespective of the treatment. So if he discontinued the treatment and he had a bad response, he will still be in the treatment arm. So this is a very, very important parameter to look at as to how the study was formulated. So intention to treat means that they are actually looking at a real world sort of a thing also. If you've lost a follow-up, what happened to the weight becomes important from that perspective. So individuals from 12 to 18 years who were obese or overweight with complications. Now, I would be very wary of giving anybody who is overweight injectable preparation. So there was only one patient who was actually there. Maybe they wanted to get more samples. That's why they were a bit scared. They added overweight. But overall, only one patient was overweight. So it's mainly obese individuals that we are talking about. and they should have had a documented weight loss attempt which was unsuccessful. The exclusion criteria were, of course, that if recent changes of weight was more than 5 kilograms, if they had received a medical treatment for obesity in the last 90 days, of course, if they had undergone a bariatric surgery, because bariatric surgery will impact the GLP axis in a big manner. That's another thing. Any condition which may alter the response, depression, secondary causes were also excluded from there. There was a run-in phase in which 12 weeks they had to educate everybody about lifestyle, physical activity, and then they went on with the intervention in that regard. There was a behavioral intervention as well. Now, this was a randomized trial and they used 2:1 ratio. So there were 2 treated patients versus 1 placebo in that regards. And they were randomized as far as the gender and puberty status. All of you should go and look at the way the study has been designed, and they are mentioned because they are very nicely put forward what the ideal study should be. So they had specific techniques about randomization as well. The treatment here was semaglutide was started at the lowest possible dose of 0.25 milligram per week, and then was escalated over a 4-month period to 2.4 milligram per week, or the maximum tolerable dose. So again, first 12 weeks was more like titration or allowing. And this happens with most GLP-1 analog. If we talk about the Trulicity injection, if we talk about Rybelsus, we start with lower doses and build it up to allow GI symptoms. The duration was 68 weeks. And this 12 weeks was the initial phase plus 56 weeks from there. And then 7 weeks they followed up without treatment. So overall 2 weeks of run-in period, 12 weeks of building up the dose, 56 weeks of actual treatment, and 7 weeks subsequent. So it's a big follow-up data which is there. And when I'll tell you that there was a retention rate of 99%, which basically tells us that they were able to really follow up very well in terms of their data, and they had hardly any loss to follow up. So if you have intention to treat, you don't want to lose anybody to follow up, because that will be a bad outcome measure also from that regards. Now, what would you like to look at in terms of efficacy? The obvious thing would be is how much did it make a difference in terms of BMI? So their primary outcome measure was a percentage decline in BMI. The secondary outcome measure was those individuals who received a 5% or more decline in weight. So they were their 2 major outcome measures. They also looked at the other parameters like BMI, SDS, weight, waist circumference, HbA1c, ALT, lipids. A lot of other parameters were also looked at. But the study was powered mainly for percentage BMI decline. So this is another message. So when I talk about the numbers, the number was such that 90% power was there for the BMI decline. And for weight decline, the power was 71%. Now, what I'm trying to say is that they were less powered to identify a weight decrease. Now, if they find a weight decrease, what does it mean? So their power was 71%, but if suppose, and we'll talk about when we talk about the study, Vibha, is that if they find that there was a decrease in weight, do you think this is right, or they were underpowered, or what was the significance? Manoj? So they were not powered to 90% to find a difference, but they found the difference. It means that there is a huge difference. Suppose you are supposed to have spectacles of, let's say, +2 to get a vision. But even at +1, if you're differentiating between the two, there has to be a bigger difference. So even at lesser sample size, if you're making a difference between the two, the difference is huge. If you do not find a difference, then you can say, okay, I was underpowered, and maybe if I had 200 people, I might have picked up. So power is more for missing out. But if your power and you are still identifying the difference, that becomes significant. So this is important. So remember, 90% power was mainly for primary. This one was underpowered, but whether they found a difference, we'll talk about that a bit later. They, of course, looked at other things like quality of life and safety, very importantly, predominantly GI symptoms, heart rate, pancreatic issues, calcitonin, because theoretical concerns about medullary carcinoma, thyroid, other things are also there, which you have to be worried about in that perspective, and mental health. But the key thing to look at was how much did the BMI come down? That was their crux of the entire assessment. Now, this is the baseline characteristic, not much to look at. The mean age was pretty much in the adolescent age group, 15 years. So this will be the typical age group. What we are seeing also is that most patients were in the late puberty stage. So of course, adolescent, we're talking about that age group. The BMI, also most were late pubertal. The BMI standard deviation score was approximately 3.3. So there was a significant obesity. So they have told overweight, but only one child was overweight. So it was pretty much obese. But if we look at our obese adolescents, they will be similar to the same age group and in terms of BMI. High levels of obesity, and 4 patients were diagnosed with diabetes. Now, in diabetes, if they were just being managed by a metformin, they accepted the patient. Otherwise, they did not. So 4 had diabetes associated, which was picked up on follow-up. And this is a big study. We're talking about 201 individuals, out of which 2/3 were given treatment and 1/3 were given placebo. It was a double blind, so nobody knew which is the preparation there. Now, next step is what did they really find? And if you look at the primary outcome measure, what you can see that placebo, pretty much there was hardly any difference as far as the BMI is concerned. But this is an impressive decrease of approximately 16% in terms of BMI standard deviation score. But what I'm seeing there is that there is an upclick, which is again happening towards the end. So remember the figure that I was talking about in terms of liraglutide in adolescents, there was a huge resurgence after that. This follow-up is less, but within 7 weeks, again, there is some regain happening, but still there is a substantial difference. The other thing to look at that out of 134, 131 were there till 68. So it's a huge issue in terms of compliance was very well maintained. Placebo 67, 62. So good numbers were there throughout the study and they use intention to treat analysis. So there is a dramatic decrease in terms of the BMI. Major difference happens from 12 weeks. There is a plateau probably happening beyond 52 to 68. So probably after this, you don't gain much. But this is the big question, what happens after you stop the treatment? Whether they had a rebound, this will be an important factor. And the second parameter, as I said, how many of them lost weight of 5%? It was 73%. Then 62% lost 10%. And at 20% also 37 people had 20% weight loss. So somebody who was 100 kgs lost 20, become 80. So this is a big message. And in the placebo, of course, this number was very, very small. So there is a good decrease in terms of BMI, a good decrease in terms of absolute weight loss. So both primary and secondary outcome measures are there. So now what I was saying that the power was less, but if suppose you have to compare an elephant and a rat, you don't need any power. You can say one sample, you can make a difference. If you're comparing 2 different types of horses, maybe you would need much longer type of sample. So here the difference is so huge, you don't worry. Even if your sample size was 15 or 20, maybe you might have found this difference because there is a huge difference there. So this is the understanding of power that you come from this study. Now this again is talking about the change in BMI. So what they are saying is that more than 20% reduction in BMI was found in 40% cases. So this was again a huge. So there was a good benefit which was there. While here the numbers in placebo was much, much lower in that perspective. So if you look now, the change in BMI is minus 16.1 versus 0.6 plus. So there is a 16.7% decline in BMI differential in that perspective. There is also that 73% children had a weight loss of more than 5% versus 18% in the placebo. There is also a decline of around 1 standard deviation score. So remember, we said 3.39 was to start with. So again, 20-25% reduction in terms of BMI STS. Compare this to liraglutide, the figure was much lower. Compare this to orlistat, it was only 5%. So there's a substantial decline that you're seeing. 15 kg loss, average weight loss versus 2 kg weight gain. So good amount of weight loss. I will be happy with that. If you talk about bariatric surgery, the typical weight loss is around 20 to 30 kg. So this is a good weight loss. So we are talking about a year and you're losing 15 kg. So I'll be happy with that. I'll still be concerned about the up. So we need to have more data on terms of follow-up. Now, if you look at other parameters, that this is what it shows, that there was a decline in BMI from around 28 weeks, around 6 months to 1 year was the peak time when you have a good response in terms of BMI. And same was true for the body weight again from that perspective. Now, if you look at other parameters which were there and they looked at waist circumference, there was a substantial decrease in blood pressure, marginal decrease, also some decrease in terms of ALT levels. So this is important. We know that these groups of medications are good for fatty liver. So there is a 20% reduction in ALT levels, which were also noted in that perspective. So overall, it seems you're coming down on BMI, you're coming down on weight. So of course, comorbidities will also come down in that perspective. Now, what about adverse effects? So of course, the main adverse effects were predominantly in terms of the gastrointestinal. 4 individuals developed a gallbladder stone. So you have to be careful about if these patients complain of pain, it's not just acidity or bloating. Get an ultrasound to look at a gallbladder stone, whether it is there or not in that perspective. So gastrointestinal symptoms were predominant. Others, there was not much difference in that perspective. So now whether this study should change our practice or not is the question. So the authors conclude that there was a good response to 2.54 milligram weekly in terms of response. All other parameters, complications also improved. And what they said that their findings were consistent with other studies in adults. So which seems reasonable that we have got a good response in that perspective. The important observation was that the reduction was much more compared to other drugs. We talked about the combination of topiramate. We talked about the liraglutide or orlistat. The response is better than this. And their percentage point was approximately 17.4. And they said that their 60 weeks seems to be the good time. So as I said, 6 months onward, there is a response. 1 year is the best time when you get the maximum response. So how long to treat? That will probably give you the answer from there. Now, there was also improvement in the quality of life and other parameters. They do write a bit about the rebound weight gain and whether this will happen. And they say we need to follow up more on that perspective. So if we now really judge that, this is an excellent design, prospective randomized trial. Intervention is very clear, very well monitored. Population also is the same that we see obese adolescents. Subjects were definitely generalizable. Intervention is feasible and hopefully it will be available also soon because based upon this, they have applied for the FDA approval. And the impact is a good impact of 16%. So this is a positive study overall, which talks about a novel way of managing diabetes. I'll be happy if there is a 1 year reduction of 15 to 20 kgs in a child who is 100 kgs. And this will, of course, cut down on complications. So we need to watch the space as and when semaglutide is available. Now, oral semaglutide is available already. Now, next step would, of course, be to think that in the treatment of obesity. So that will be the next step. And then it will make life much easier rather than injections, because injections will be the new thing. So just to summarize, we have got a novel option which is available, which has an impact on gastric emptying and satiety, and which can have a dramatic improvement in terms of food restriction, causing overall weight loss in that perspective. So we will now continue the next part of our journal. This is from Dr. Vibha, who will be talking about this study of maternal thyroid dysfunction and neuropsychological development in children.
Thank you, sir. Good afternoon, everyone. This journal is from JCM. And as we all know that thyroid is very important for the fetal growth and the development. And before the 20 weeks, as the fetal thyroid is not developed, so the development of thyroid is entirely dependent on the maternal thyroid. So for maternal thyroid status is really very essential for the development in children. So let's see, why do we need this study? Because there are many data on the studies, like we know overt hypothyroidism has an impact on the IQ level, on the intellectual ability. We know there are many studies that shows that even hypothyroxemia causes autism, intellectual disability in children. But if we talk about the entire spectrum of the thyroid, like the overt hypothyroidism, subclinical hypothyroidism, there is very few studies, very rare data is about like what happens if mother has overt hyperthyroidism or there is subclinical hyperthyroidism, what happens to their offsprings, whether there is any neurological issues in their children. So that's why this study was designed, because the effect of the maternal, entire spectrum of the maternal dysfunction on the neuropsychological development in children is, and the results is really inconclusive. So let's see how the study was done. It was a prospective cohort study, and it was aimed to see the association between the maternal thyroid dysfunction and the neuropsychological development indices at 6 and 24 month of age. It takes all the spectrum of the maternal thyroid dysfunctions, like the overt hypothyroidism, subclinical hypothyroidism, overt hyperthyroidism, subclinical hypothyroidism, even the hypothyroxanemia and the hyperthyroxanemia, and to see sex dimorphism in the neuropsychology, whether the boys gets more affected or the girls gets more affected. And in the inclusion criteria, they took all the pregnant women with a thyroid disease during the pregnancy and children participating in the neuropsychological assessment at the 6 and the 24 months. And they excluded all the pregnant women with pre-pregnancy thyroid diseases and if there was any history of mental illness.
So this was only those individuals who had diagnosed
During the pregnancy, yes, sir.
So this is very important because many patients come to us with a first time report of TSH more than 100.
Yeah.
As to what will happen to their infants, and this will be an important message from them.
And if there was neonatal death or birth defects, or they were twins, so they all were excluded from the.
Given to all the mothers.
I'll talk about. Now let's see what they do. The participants were 4310, and they have excluded all those in which the thyroid hormone reports were not present, pre-pregnant, those who have pre-pregnant thyroid diseases, mental disease, mental illness, assisted reproductive technologies, birth defects, neonatal death, and the twins. They all were excluded from the studies. And after this, only the 2341 eligible pregnant women were eligible, and from these, the missing data on the neurodevelopmental assessment in infants, that were 503, were also excluded. So the final infant and the mother pairs were 1838. So the neurodevelopmental assessments were done in 6 and the 24 months. It was done in Shanghai between the 2013 and the 2016 year. And maternal FT4, TSH, and TPO antibody was done during the antenatal checkup.
Was this part of some other study or specifically?
Specifically this time, sir. All the the mother included in this, gynae ward, they were included.
This is a very impressive study because you're talking about follow-up for a long time in these.
And the neuropsychological development assessment was done in the very crucial period of the first 2 years of life. So the maternal thyroid status was defined according to the Chinese guidelines, and I have mentioned the link below. And they have defined the euthyroid if this FT4 was within the 2.5 to 97.5, and overt hypothyroidism if the FT4 was greater than 97.5 and TSH was below 2.5. Overt hypo if FT4 was less than 2.5 percentile and TSH was greater than 97.5. Subclinical, as per as you can see, and they were.
What was their 97 percentile for TSH? Did they mention that?
No, sir. It was just only given.
So roughly we can say it will be like 4. That will be the typical one. That will be subclinical. Above 4 and FT4 being normal. Sure. Okay. So,
and neuropsychological assessments in children was done at 6 months. They have followed the ages and stages questionnaire, 3rd edition, ages and stages questionnaire, social and emotional. In the ASQ3, 30 domains, 30 items over 5 domains were included, and in which communication, gross motor, fine motor, problem solving, and personal social domains were included. And 10 points were given if they give the answer was yes, 5 points were given if answer was sometimes, and not yet if the answer was not yet, 0 points were given. Maximum score of each domain was 60, and higher the score, better was the development. And in the ASQ S3, 90 to 33 items were included over 7 domains, and they have included self-regulation, compliance, communication, adaptive functioning, autonomy, affect, interaction with people.
This is at 6 months.
This is, yes, sir. This is 6 months. ASQ3. Ha.
Self-regulation.
This is. Rarely or never, they have given 10 points, sometimes 5 points. Higher the score, poor performance in the social emotional domain. Now, at the 24 months, they assess the child according to the Bayley scales of infant and toddler development, edition 3. And it includes 5 domains: cognition, language, motor, social emotional, and adaptive behavior. Higher the score, better the performance. So they have included a lot of domains to see the better development of the child. Now, if we see how the statistics was done, there was lots of confounding factors, and for which they have adjusted well, which was maternal age, gestation week at thyroid testing, gestational age, birth weight, TPO, gestational diabetes, hypertension, infant sex, passive smoking, and feeding patterns. All were adjusted, and they have to find the association. They follow a generalized linear regression model to estimate effect size with the class of interval 95th percentile, and two-sided p-value less than 0.05 was considered statistically significant. Now, let's see what they found in the result. This is the characteristics of the study population. If we see, the mean maternal age was 29.3, and the birth weight, the average birth weight was 3.3 kg. The gestational week at which the thyroid function test was done was 12.3 week. And they have classified the thyroid in the euthyroid, overt hypothyroidism, subclinical hypothyroxemia, overt hypothyroidism.
So around subclinical and overt were equal. Normally the figure which we talk about is overt hypothyroidism is roughly around 2% or something, and subclinical approximately 10% overall in pregnancy. But they found 4.1% as overt and 4.0 as subclinical. Equal. 3.7 is hyperthyroidism. So this is a bit unusual. So hyperthyroidism frequency is as much as hypo. So which is a bit unusual, but anyway.
And the gestational week at which the treatment was given. You were talking about the treatment. They gave the treatment.
So every subclinical was given a treatment?
Yes.
Okay. So what they are looking at is that if you have very conceptual high level of research, what happens? Because unidentified hypothyroidism, what is the impact? And they have also found at what peak the treatment should be given, but they have given 14 treatment and 14.9, and let's see what happens in the result. So what they are saying is 12 weeks to get the function. So within a 2 weeks they would have started treatment wherever it was required. Now in the result, if we see, let's see what happens. In the overt hypothyroidism, in the 6th month, in the boys, if we first see in the boys, in the 24th month, the motor, the social motor, the emotional social were affected more in the boys, and in the subclinical hypothyroidism, the social emotional were more. And if you see in the girls, in the overt hypothyroidism, the personal social were affected too. So what you're saying is that if you go step by step, 6 months and 24 months in boys, the major impact is in terms of the 24 months only, and that is in terms of the motor skill and social emotional. And if we see the impact, and there the higher score is better. Yes. While 6 months, the lower score is better. Yeah. And what you're saying in girls? If we see the impact of the overt hypothyroidism girls, their personal social is more affected. And if we see the impact of the subclinical hypothyroidism in boys, the more impact is on the social emotion at 6 months.
And if we see the impact of the hypothyroidism in boys, it is more in the motor domain and it is more in the motor domain. And they have found no association of the overt hypothyroidism both in the girls and the boys. And if you see the effect of the subclinical hypothyroidism, it is more in the girls, but they have found no association in the boys.
So essentially what you're saying is that if there is overt hypothyroidism, there is some impact which is there. Probably not much impact of subclinical hypothyroidism or other forms. This is what it is coming out.
If we summarize it, the maternal hypothyroidism, they have poor performance in personal social domain, and the subclinical hypothyroidism, it gives the poor performance in social, emotional, and adaptive behavior. The subclinical hypothyroidism affects the language domain, and the hypothyroidism was associated with poor motor scores. And the overt hypothyroidism was not associated with any changes.
So why do you think hyperthyroidism is not associated with things? No, so basically you won't have that much elevation in TSH T4 levels in babies because only 40% is going. So you will not develop thyrotoxicosis because of that. But if you are low and mother is supplying the main amount of T4 in that phase, you may develop effect of hypothyroidism. So the effect of maternal thyrotoxicosis is actually because of the TSH receptor antibodies crossing the placenta. It's not because of the thyroid hormone. So at this stage, nothing will happen. So your effect will mainly be overt hypothyroidism. I don't expect subclinical to have an effect. Okay. Subclinical will have an effect on placental functions. And it may cause prematurity, it may cause miscarriage and other things, but it is not expected to cause maternal fetal outcome effects.
But they have some effect of subclinical hypothyroidism.
What I'm trying to say that if you really look at so many things, one or two things may be a problem.
Okay.
But the gross differences were there in overt
and subclinical hypo, right?
Subclinical they were there.
Okay.
If you look at the previous literature, there is some effects in terms of few IQ points is what people have talked about in terms of older age groups. The effect is of few IQ points, but it is not that much. In our experience, we have seen many patients who come for the first time with a TSH of more than 100. Once you start treatment at the right time, you will be able to achieve a good outcome.
Right. The boys appears to be more sensitive to the negative effect of the maternal overt hypothyroidism in the motor domain at the 24-month, while the subclinical hypothyroidism affected social, emotional at 6 months and adaptive behavior at 24 months. While if we see the girls were more affected in personal social domain at 6 months with overt maternal hypothyroidism, while subclinical hypothyroidism affected the language domain at 6 months. This is the aim. They have also aimed at whether there is a sexual dysmorphism in the impact of the this thyroid dysfunction of the mother in the boys or the girls. So they have found this. There is some sexual dimorphism in the impact, and the infants of overt hypothyroidism mother treated with the thyroxine at 14.4 weeks have poor language and motor domain. In the previous study, they have mentioned if the babies are if the mothers are treated before 14.3 at the 13 weeks, they have better outcome.
So the main question which are there, which will come to you is what is the right time to do a TSH screening? So if you're talking about TSH screening from a perspective of pregnancy outcome, immediately as soon as the pregnancy is diagnosed. Why do you want to delay it? Because the brain development is happening around somewhere around 8-12 weeks, you start having all those developments. So better to pick it up early. 14 weeks is pretty late. If you're screening for at 14 weeks, your abortion risk and all those things would already have been there. So best to do it the first visit. That if you want to really think about it, do it at the first visit. And don't wait for treatment.
So we talk about the generability, whether these results are generalizable or not. The study is a prospective design, which is a good design really. And they have really talked about the broad spectrums of the maternal thyroid disorders, because the previous data have only talked about only the overt hypothyroidism and the subclinical, but they have shown some data about this hypothyroxanemia and the subclinical hypothyroidism. And there is a really good follow over the first first two crucial years of development, which have given a wide spectrum of that, like which major domains could be affected if there is a maternal thyroid dysfunction. But they have further divided the thyroid dysfunction into overt subclinical and the hypothyroid. So it has reduced the sample size. So we cannot generally extrapolate these 50 sample size over the large population. So the impact of this study is that they have adjusted all the confounding factors present in the study, and the positive impact is that the data on the this dimorphism is really very rare and inconclusive. So they have provided a good data on this. And we should monitor all forms of thyroid dysfunction, not we should go for only TSH. We should also measure free T4 along with the anti-TPO antibody. We should start screening right from the beginning, because we have seen.
Are you recommending that every mother should have FT4 TSH diagnosis?
At diagnosis,
And in pregnancy?
Obviously, sir.
So the Endocrine Society guidelines and the ACE guidelines, still ATA guidelines, still don't talk about even TSH in all mothers.
Yes, sir.
So this, if you have to think, giving based upon one study is okay. But if you recommend, there are so many deliveries happening. If you start doing all those parameters, it will be not cost effective. Because you are not even doing TSH screening in newborns, talking about FT4, TSH, TPO in all mothers will become huge.
Okay.
So generally, ART and other infertility treatment, there all this is recommended.
Okay.
But if you look by the study, you can say probably if you are looking at what is the impact was subclinical hypothyroidism at mild and overt. So TSH alone will be a good strategy.
So, but in TSH, if we don't go for FT4, then how would we able to live?
So if you find the TSH to be high, then you can go and work up further, or you can start treatment in that perspective.
Okay.
So because you have to think about generalizability in everybody. Every patient in India, if they start getting FT4 TSH, the affordability will be a big issue.
Okay.
I think this was an interesting study. The key messages which I think we can take from this study are two. If you want to measure thyroid, do it as soon as possible. As soon as the patient comes to you with pregnancy, get a TSH. If it's high, start treatment. That makes sense. I would not go for everybody doing FT4, TSH, TPO. It's not going to make a huge difference. Somebody who had a form of hypothyroidism which was picked up late was overt hypothyroidism, monitor for neurodevelopmental outcome. I think this will be the key message from that perspective. Now, other big study, which probably is a big challenge, is we are seeing so many patients who have got dysglycemia in the setting of obesity. Individuals in which you have got variations in sugars, which is the best parameter to identify that? Is it the fasting glucose, the 2-hour glucose, the HbA1c, or some other parameter is a challenge? Because if you are able to identify those who have dysglycemia, you can intervene further. So Dr. Manoj will talk about this study, which compared the various tests to identify dysglycemia in children and adolescents.
So thank you, sir. Good afternoon to all. So today I am going to present about the journal club about the obesity. In India and all over the world, obesity is increasing dramatically nowadays. Every fourth obese children in the USA and India has a diabetic obesity complications. And we have to think about the complications, because obesity comes with the all complications like type 2 diabetes, cardiovascular problem, raised SGPT level, and altered lipid profile. So if we don't treat at the right time, then it can cause the type 2 diabetes and cardiovascular complication. So this study has been done in the USA, Michigan University, and the paper is about to publish in 2023. So if we start about the background of the study, then for the picking up the dysglycemia in the obese child, we have now in India we are using now three most parameter that we are using. One is HbA1c, fasting blood sugar, and OGTT. Among all the three criteria have the drawback and positive points. What are the positive points for the HbA1c? HbA1c is easy to do. no need of the fasting for the HbA1c. But there are low sensitivity and specificity for the children perspective, and it affected by the RBC turnover. So whenever child has a hemoglobinopathy, the HbA1c has a no value. Second, the fasting blood sugar and OGTT. So fasting blood sugar has a low sensitivity and OGTT has a low reproducibility. Here, reproducibility in terms of the precisions, because if we repeat the sample it again, then the result would be the different. So it would be not in the same precision criteria. And there are the limited data of the 1 hour glucose load in the Indian perspective. And what about the other non-fasting parameters rather than the HbA1c? So if we talk about the fructosamine and 1,5 N-hydroglucitol, then it is not, the data is not available in the Indian's perspective and all over the world also for the peaking dysglycemia. So in adult, there are some studies has been done which shows that there are the higher non-fasting level of the HbA1c and RBC is linked with the high risk of the future development of the type 2 diabetes. So taking this study in our mind, and in the pediatric perspective, there are the limited data, and during the puberty, because puberty is a state of the insulin resistance where insulin sensitivity is high, very less. So in this at this point, the diagnosis of the dysglycemia is very difficult. So if I start my journal club, then what are the objective of this study? The objective of the study to evaluate the prospective test performance or the non-fasting blood sugar like random blood sugar, HbA1c, 1 hour OGTT, fructosamine, and 1,5 N-hydroglucitol to identify dysglycemia in obese children. And the type of study was a longitudinal cohort, and the study duration was 1.1 years, and the total 4 visits was included in these studies. So what are the inclusion and exclusion criteria? So they have considered overweight and obese, more than 85 percentile of sex and age, and the age group was 8 to 17 years of age. Here I want to highlight that they have mentioned overweight also. And what are the exclusion criteria? Any known case of the diabetes or medication that altered the glucose metabolism, and the pregnancy was excluded. So what are the study design? Baseline, they have done they have taken anthropometry data, vitals, and the basic laboratory parameters. If I start according to study, then at the visit first, they have taken this fasted sample, which contains the fasting blood sugar, HbA1c, 1 hour OGTT, 2 hour OGTT, and the minimum fast for that required was 12 hours. After 1 to 3 weeks, to see the reproducibility, they have given 50 gram of the glucose, and they measured 1 hour OGTT, not 2 hour OGTT.
Like a pregnancy in which they do a glucose challenge test,
yeah,
something like that. So I think the reason why this study is being done is that doing a proper OGTT with a fasting sample will be difficult. So what they're trying to say, okay, I don't want to do a fasting in PP, I want to look at something else. Patient comes, I'll measure HbA1c, I'll measure AIG level, I will measure GCT and get an immediate diagnosis. So are they considering the OGTT as the gold standard? So what's the gold standard of the outcome?
HbA1c.
HbA1c is the gold standard for it. Okay, carry
on. And the patient has called for the follow-up for the visit 3 and visit 4 after 1 year of the duration. And at the visit 3, they have repeated the oil sample which they have taken at the first visit, like glucose, fasting blood sugar, HbA1c, fructosamine 1.5 ag, and 1 hour and 2 hour OGTT, and the visit 4, they have repeated the fasting blood sugar and the 2 hour OGTT. Here, criteria for the picking of the dysglycemia was according to ADA guideline, which contains the HbA1c level more than 5.6, fasting blood sugar more than 100, and the OGTT more than 140. And if we see the baseline data, then they have included 176 number of the patient total. Here, the female number of the female were higher than the male, and they have included 58% of the obese patient, while among them 43% were overweight. So here they had a mixture of the overweight and obese. If we see about the pubertal status, then the most of the children in the male and female tenor state, they were the pubertal or the post-pubertal. And at the baseline visit 4 and visit 3, the 18% patient have an abnormal HbA1c, and 28% patient have abnormal glycemic parameter or HbA1c. So if we see the outcome, what they want to see, they have to taking this all the data into consideration, they have created the ROC curve, and they have measured sensitivity, specificity, positive and negative predictive value of individual parameter. So if I start about the outcome, then
To what?
about the baseline parameter in comparison to predict the final outcome.
So the gold standard is the final outcome and not the HbA1c. So final outcome is whether they have dysglycemia or not. So this is very important to remember. What they're trying to do is that what this is telling now and what is going to happen 1 year later. This is a very, very important parameter.
Okay. So here first I want to discuss about the reproducibility. So they have compared the result of visit 3 and visit 4. So at the visit 3, 6 participants of impaired fasting blood sugar. Among them, 5 became normal. So the reproducibility of the fasting blood sugar was poor according to this study. And 2 normal participants with the fasting blood sugar, they develop impaired fasting blood sugar. If I talk about the oral 2-hour plasma blood glucose test, then at the visit 8, among 8 participants of impaired 2-hour OGTT, 5 became normal, and 2 normal participants become abnormal at the duration of the 1 to 3 weeks. So it is suggestive of there are the less reproducibility of the fasting and OGTT. And what?
HbA1c twice also. They should have checked that also, because then you will get to know really whether the reproducibility, because we're talking about minor number. We're talking about HbA1c of 5.6 and 5.8. That will make a big difference. So that probably will also be an important factor to look at.
And here
glucose variability, anyway 10% is within the mean absolute relative difference of 10% is considered to be a reasonable one. So if somebody was 105 and he becomes 95, this is within the coefficient of variation. So you can't say that there is a poor reproducibility. Every of the parameters will have that.
But about the OGTT also reproduces.
Yes, so 10%. So glucose variation. So somebody is at 140, he would be 126 the next day because 10% is within the range. So that value also you have to consider. This is part of the glucose test. Same about HbA1c, we need to know how much is the reproducibility.
And at the outcome, 5 to 10% normal baseline glycemia participate at visit 1 become abnormal at visit 3 and visit 4, and 40 to 78% of patients with the abnormal baseline parameter remained abnormal. So if I
progression was only 10%.
Yes. Visit 3, they have done all the parameters.
Not at visit 4. Visit 4, they did not do. So 3 and 4 is just like 2 weeks apart.
1 to 3 weeks.
So what we are saying, just hold on. What we are saying basically is that if you look at follow-up, most patients who were abnormal, they remained abnormal. But there were few who were normal became abnormal on follow-up. So there was a progression happened in around 10% of cases. And what was the baseline rate of dysglycemia? How many had?
Sir, baseline rate of the dysglycemia, if we compare
less than 10%. So 161 and 15 basically were abnormal. So there was not a huge. So it was like because a lot of overweight patients were there, you're looking at around a figure of around 10%. prevalence of this. Carry on.
So if we compare about the if we see according to the ROC curve, then at the first column, it was a fasting, it was the glycemic parameter with in the comparison of the HbA1c random blood glucose 1 hour glucose challenge test. The cutoff point for the all three for the baseline HbA1c random glucose and 1 hour OGDT shows the similar result. The result, the point was around 0.7, 0.68, and 0.78. So they did the similar performance for the predicting glucose-dependent glycemia parameter at the final outcome.
But these are not very good. 0.7 is just the tip area under the curve as far as the ROC curve is concerned. So they're not correlating very well. Can you?
If we talk about the final HbA1c level, then the baseline HbA1c level has predicted a good outcome in terms of the cutoff point of 0.93. About the RBS and about the 1 hour challenge test, they have shown only 0.60, 0.67, and 0.57. If we talk about the baseline combined glycemic parameter, then again HbA1c did the good performance, with the cutoff point of 0.81. And where the other cutoff was not good enough.
So what are you telling about is basically that if we look at somebody at the start and we look at HbA1c fasting 2-hour value and you want to predict what is going to happen after 1 year, HbA1c has got the best diagnostic accuracy. That's what you are saying from this regard.
Yeah.
And did they come up with a cutoff?
Yes, cutoff. That I will discuss in subsequent slide. So if we compare about the whole table, then HbA1c did the good performance in terms of the 0.7, 0.93, and 0.8 cutoff, 0.81 point. And if we compare about the fructosamine and 1,5 N-hydroglucitol value, then they did the poor performance. The cutoff point was less than 0.5. So it is, the taste was not good and not bad. So it was like coin.
It was worse than
Flipping a coin.
0.45 is worse than the point.
So they didn't show the good nice result for the prediction of the dysglycemia. So if we talk about the sensitivity and specificity to outcome of the glucose-dependent dysglycemia, HbA1c had a low sensitivity around 25% with the higher specificity of the 96% if we take the cutoff of 5.7%. But if we reduce the cutoff from 5.7 to 5.4, then the sensitivity is double, but it is not again very good, like 56.
Are you happy with this?
No.
What does it mean?
No.
What does it mean in simple terms?
Means only 56% patient was able to pick up by the HbA1c level of.
So if we had 100 people who had abnormal fasting glucose or other glucose, right, 44 will be missed. So there's no point in having that. So that means that is a different thing. HbA1c is a different thing. Probably this is what is coming on, because you will not. It's a screening test. You want to have a high sensitivity. 56% sensitivity is of no meaning. Yeah, carry on.
So here they have mentioned that sensitivity is very low, but specificity is high. So to 96%.
What is the point?
Okay.
So they will mention, but you have to tell yourself what does it mean. What about the other things?
So if we take as the combined outcome as a parameter, then HbA1c threshold of 5.7 for the predicting the combined outcome, which contain the fasting 2 hour and HbA1c, then the sensitivity is only 29% with the specificity of the 98. But if we take the cutoff of 5.4, then also sensitivity become not huge, like 64%, and specificity is 81%.
So what it basically tells you is that if HbA1c is high, then you are okay. There is a problem. If HbA1c is low, you can still have problem. So this is the main rule. So if your HbA1c is above 5.7, you can assume that 98% there will be a problem. So I think the role of HbA1c would actually be in ruling in a problem. If HbA1c is high, diagnosis is made. So it's more like a confirmatory test rather than a screening test.
So if we talk about the random blood glucose value, then that had a severe low sensitivity at the threshold of 100 milligram per deciliter. So if we cut off this 100 is abnormal, then also the sensitivity is only 53 to 61%. And if it at the 90 milligram per deciliter, specificity is 58 to 66.
So they did not look for 70 or something.
What's that? No.
So they did not look for 70 because it doesn't make sense. You
It's
100 itself
100 is
very
high.
low. There's no point looking at 90. Then how many? You're talking about 90. How many of them will be above? Everybody will be above 90. Then you start getting unnecessary worked out. So what they're saying is that random sugar is basically useless in terms of evaluation. Next.
So now we compare about the 1 hour glucose tolerance test. Then it has shown the lowest sensitivity among all at the threshold of 110, which is very low. So the sensitivity is 53%, 39%, 49%, and specificity of 85, 84, and 85 in to the predicting value of for the glucose-defined dysglycemia, elevated HbA1c, and abnormal glucose level. So in summary, the it has a low sensitivity.
So it is not good. Carry on.
So HbA1c remained the strongest predictor of the combined outcome of glucose-defined dysglycemia or elevated HbA1c.
But it is also not good enough. So what they are basically saying is that you have to do everything. You have to do a fasting. You can't miss the fasting value. That is very important from that perspective.
So here, if I conclude this study, then HbA1c had good specificity but very low sensitivity, and the RBS 1 hour OGTT may be given can give additional benefits if the HbA1c is not possible where the hemoglobinopathy is present. And if we talk about the fructosamine and 1.15 Ag level, then it showed the poor prediction for the glycemic for the dysglycemia prediction. So for the evaluation of this study, the outcome, what are the limiting point in this study? They have seen the combined outcome for the fasting and 2 hour OGTT. It should be a different outcome for the these two different pathophysiology. And the population selected, what the population they have selected, they combine the obese and non-obese patient, overweight patient. And pubertal assessment here was self-reported, and some were reported by the parents also.
Not make a difference. The major problem was that you were studying in an overweight age group, in which the prevalence of this disease will be very less. If your prevalence is very less, then all these sensitivity specificity will have limited use. If they had focused only in obese, and I assume that only obese would have had all these problems, the prevalence would have doubled. Then you will find a better differentiated feature.
And they didn't take into the consideration of final BMI changes, which is not linked with the outcome. So if we see the generalizability, then the cost is an issue in the Indian perspective, because in Indian OPD, we can't do this investigation for all the patient. And here 1 hour OGTT has a limited value because of the reproducibility issue, and the role of the fructosamine is in this setting, it is a questionable.
So I think this was a good study, which is basically looking at a parameter of what is the best predictor which is going to happen over 1 year. So what does it mean? That if you find somebody who has a high risk, you will start doing more intervention. Maybe think of metformin and other parameters. But again, the problem is that they are not able to get the right outcome. So you are suggesting that we should have for only obese individuals and do more parameters to look at to study that. I think this was an interesting phenomena. We will have the final discussion on a very important topic again in terms of improving the outcome in the setting of type 1 diabetes management, and how technology can help and how monitoring can help. So Dr. Dhwani will talk about this study which is being published in JCEM, the current issue.
Thank you, sir. Moving on to the final case. This was a recent article in JCEM, Teamwork Targets Technology and Tight Control in Newly Diagnosed Type 1 Diabetes Patients. So we know that we've come a long way in the diagnosis and management of type 1 diabetes. The ancient scriptures describe classical symptoms of polyuria, polydipsia with early deaths in children, but it was not until Oskar Minkowski and Joseph von Mering discovered the role of pancreas in causation of diabetes. following which Paul Langerhans described the beta cell of pancreas. And we know that Banting and Best isolated insulin and MacLeod and Collip helped in purification of the animal extracts of insulin. This is when we came up with the management of insulin. Even as far as the management is concerned, once insulin was discovered, we came with better insulin delivery devices, from syringes to pen to the continuous infusion pumps. So we know that the management of insulin has diversified significantly. Even looking at the diagnostic modalities, we had initially the urine dipstick, then we moved on to the self-monitoring blood glucose device, and now to the continuous glucose monitoring devices. So the step forward in management of diabetes, it has been progressive. Landmark trial in type 1 diabetes management was the DCCT trial, which studied over 4,000 patients over a period of 15 years. And the results found were that superiority of intensive blood glucose measurement and control in reducing the incidence of complications in type 1 diabetes. Maintaining HbA1c around 7 reduced the risk of long-term complications, and period of sustained glucose control helped to protect against long-term complications, even when the aggressive therapeutic options were stopped. Also, there has been study to show that clinically meaningful and lasting HbA1c improvements are rare after first 5 years of type 1 diabetes, and that uninterrupted continuous glucose monitoring access is associated with decrease in HbA1c in youth with type 1 diabetes. So this is how the idea for study was initiated. This was a single-center cohort study, which looked into so there was a historical cohort. These were the patients before initiation of study, who, like all our diabetic patients at diagnosis, the family was counseled about the diagnosis, the treatment options, the long-term care, and diet and exercise. Then there was a fellow attached to every patient who, for the first 2 weeks, helped the family with diabetes care of the child. And first visit was scheduled at 1 to 2 weeks post-diagnosis, again in which the family interacted with the physician, the diabetes educator, and subsequent visit was at 1 month, and then 3 monthly visit, which is pretty similar to what our diabetic patients go through. These patients may or may not be started on CGM or other glucose monitoring devices, and there was no set point to when this technology was introduced in these patients. And then we had the pilot 40 cohort. So this included youth, children with type 1 diabetes with newly onset type 1 diabetes. And again, in this cohort, the family was counseled about the diagnosis, the treatment options, like in the historical cohort. However, within 3 days to 2 weeks post-diagnosis, a visit was made to initiate CGM initiation. And in the first week of CGM initiation, the family was in contact through teleconsultations to help the family adjust with the CGM device. Similarly, again, the first visit was at 1 to 2 weeks, at 1 month, and then 3 monthly.
Essentially, they were doing CGM in everybody,
Yeah.
and they were in touch about the data, they knew the data, and they informed about changes.
Yes. So the sample size was calculated to about 120 patients. This was powered at 93% to detect a 0.5% change in HbA1c.
And when was the HbA1c measured?
HbA1c was measured 3 monthly.
Okay, and how long was the duration of follow-up?
1 year.
The big problem here might be that there is a honeymoon phase happening, and some
Yes.
people may be in different phases, so that may be a bit of a
So the primary outcome studies was a difference in HbA1c at 4 to 12 months post diagnosis, and the secondary outcome study was proportion of children achieving an HbA1c of less than 7.5%, because the study was initiated in about June 2018. So they used the ADA cutoffs of 7.5%, which was defined then. So what they got was, in the historical cohort, they had about 272 patients and 135 in the pilot 40 cohort. The age at diagnosis was at 9.7 years in both these cohorts, with 50% male population. HbA1c was maximum at diagnosis with 10.7% in the historical cohort and 12.2 in the pilot 40 cohort. CGM initiation was in 56.2% of the patients in historical and 100% in our pilot 40 cohort. Also, CGM initiation, if you look at it, early initiation within first 30 days was in only 1.8% of the historical cohort. Days to CGM initiation, median of 7 days in our pilot 40. And again, another thing that we need to look at is the days to pump initiation was earlier in the CGM group.
And how many were on pumps? Did you mention that?
Yes. So
Pump use was around 50%. So 50% was on pump and it went out around 1 year.
yes.
They found around pump.
So what they found out was initially they were doing HbA1c, but because of COVID-19, there was a transient gap where they could not. The study was from June 2018 to June 2020. So they had calculated the glucose management index, which is a rough estimate of HbA, similar to HbA1c. So what they found out was that the glucose management percentage was minimum at 4th month post-diagnosis, and after which it gradually increased. Again, looking at the average CGM, which it was a mirror of the GMI, lowest at 15 to 20 weeks post-diagnosis, and after which it gradually increased. Time in range was again best at 4th month post-diagnosis, after which it gradually decreased.
So this was probably because the beta cell functions are going down.
Yes. So again, looking at it, the HbA1c in the pilot 40 cohort was slightly higher as compared to the historical. It with initiation of therapy, it went down in both these cohorts. And again, you may see that the 3-month value is higher for HbA1c as compared to the historical. But if you look at the difference, it is better in the pilot 40 cohort. Beyond this period, the values only increased. Beyond 3rd month, the HbA1c increased. But if you look at the graph, the rise in HbA1c value was steeper for the historical cohort as compared to the pilot 40 cohort. Now, even within the pilot 40 cohort, there were 2 groups. After January 2019, what they also started doing was 2 monthly CGM recordings were accessed by the caretaker team, and based on the based on those CGM readings, the insulin doses were titrated. So patients before January 2019 were not being remotely monitored, and after 2019 were being remotely monitored, and therefore more frequent changes in their insulin dosages were being made. So again, as we can see, in those that were remotely monitored, we see that the best was again at around 4 months, and beyond which there was a steep rise. There was a steady rise in HbA1c, which was slightly steeper for the children who were not remotely monitored. However, this difference was not found to be statistically significant in our study. So now that we've seen HbA1c, let's look at the time in range, which was their secondary outcome. So the first one is defined for time in range of, this is HbA1c less than 7.5% in the first one. So we can see that by, even though in the first 3 months, 75% of historical cohort had achieved an HbA1c of less than 7.5%. Beyond this period of time, it was the pilot T4 cohort who had HbA1c less than 7.5. And the second graph lower down is for a tighter control looked at HbA1c of 7%. So as we can see, it was the pilot 40 performed better. Looking at the time in range, more than 60% of the patients in the pilot 40 cohort had time in range, with very few in the hypoglycemic side. If we look at it, best control, as we know, around 4 months was the best control. So 74% were in the time in range in the at the 3-month period, after which it gradually decreased, but it remained above 60%. The proportion of Hyperglycemia was about 20% and about 5% in the hypoglycemic part. So what does this study mean for us? The age group that was defined is roughly similar to the type 1 diabetes cohort that we see in our setting. It had 50%, the sex, there were 50% males and 50% females in our study. The only thing that we cannot reproduce in an Indian setting is the availability and the access to CGM devices. But
now, if you look at overall, you're talking about a CGM associated causing a 0.5% decline in HbA1c pretty much. That's what I'm saying. So, what about the other evidences that you have? Have you looked at other studies as to how much CGM decreases the figure? Generally speaking, if you talk about 4 group of people, one who is on simple insulin, no CGMS, basal bolus with CGMS, pump with CGMS, and pump without CGMS. The best are pumps with CGMS. The second are actually CGMS. And then CGMS, if you just give pump without CGMS, it will not be of much benefit. So monitoring actually itself is a very, very important goal. So I would think that this 0.5 figure is a slightly lower figure in terms of the impact of CGM which we are seeing. The reason for that is that we are talking about a phase when you already have a very good control. So this is a time when your honeymoon phase is there. So if they had carried it forward for 2 years, 3 years, then the difference will widen up. So patients who are actually monitoring CGM, and we don't know how many of them are continuing CGM on it later on.
Yes.
If they continue CGM later, it will be benefit. But the major benefit that is coming from here is from CGM, which probably will be a bit of an issue in terms of use in everybody. But if somebody can afford it and you can give it in the initial phase, you will get a good outcome. That's what it is telling us.
So we know that CGM will help us achieve a tighter glycemic control. It will allow us to tailor dietary and insulin prescription. It will also allow remote access, so we can look at the graphs that the CGM sugar monitoring in the CGM device and provide remote access, remote care to our patients. Also, the patients may not need to maintain with the newer generations of CGM, where you may not always require checking calibration with blood sugar values. The patients are free of maintaining logbooks, and there will be no chance of falsely reported values, which we commonly come across in our OPD setting. The future potential with CGM is that if combined with automated insulin delivery, it may safely allow us to lower the glucose targets in youth with diabetes. And if it is incorporated with exercise and physical tracking, it will help us give tailored advice to children about physical activity that they should and can do.
So I think this is a good study, and it really shows us that this is the way forward. But at the moment, the technology benefits you expect is not huge in terms of that. So this is something you need to follow up from that perspective in terms of data. So now we have had discussions about 4 very important topics. One was about the use of a novel drug for the management of childhood obesity. Then we talked about the effect of maternal thyroid dysfunction on outcome of neurodevelopmental. We talked about the various parameters, and what we found was that it may be good to actually stick to a fasting PP and HbA1c rather than go ahead with other parameters. And CGM initiation at diagnosis would be a good parameter. All of you can go and have a look at our website, the courses, and the mobile application. We will see if there are any questions before we close the session. I think there are no questions. So I think this was an interesting session. We will be posting these videos as well. And we will meet again with other sessions.